Now I'd like to request Dr. Kalantri sir to come up on the stage for moderating this session. I'd like to request Bakkar sir to come up on the stage for moderating this session. I'd like to request Dr. Devidas Dahifale sir to come up on the stage for moderating this session. Now I'd like to request Dr. Rajesh Kamble sir to present on scrotal anatomy and pearls.
So good morning everyone, and I think this is my last lecture of the series and for the day. At the outset, let me thank all the committee, the Marathwada chapter for an amazing warm hospitality. Yesterday's evening was very, very memorable. I think we all had a great time, and I think all of us are all residents of Maharashtra, so Marathi Bana should remain with us. So it was a very beautiful theme, very close to my heart, and I want to congratulate the organizers who did a wonderful job of doing this in such a short span of time. Okay. So I've been told to talk about scrotum. This topic is quite close to me because I've been doing a lot of work on it since last so many years. So, okay. So basically, I'll tell in short about scrotal anatomy. It is not of any great gun. You all must be doing a lot of scrotal ultrasound in day-to-day practice. But again, wherever I go, I try to develop that as clinico-radiologist, how you should develop your approach towards scrotal diseases in day-to-day practice. So one part will be the scrotal anatomy, but the second part is your approach to your scrotal cases in day-to-day clinical practice, and that's what I call giving pearls to all of you all. So in day-to-day practice, you must be doing lot of scrotal ultrasound. So these are only two things which will bring the patient to the clinician and then to a sonologist. One is any kind of pain in scrotum or any kind of palpable swelling or lump, the patient will go rushing to the clinician. I think scrotum is one of the most important organ of a male body, and he really takes care of it well. So any kind of discomfort, he is going to immediately report to his clinician. As against if it is abdominal pain, he will sit on it for next 10 years. But scrotal pain, he is going to rush to his clinician. So there are various modalities in day-to-day practice, right from ultrasound, CT, MR. In fact, radionuclide studies in Western countries are done in a very big way for pediatric scrotal diseases. We don't do much in India about it. We all love ultrasound and then MR. So any modality today has appropriateness criteria from the Western countries. So if you go across and read this American college criteria for appropriateness, they say that a B mode sonography with a color Doppler has an excellent rating of 9. So I think the most preferred modality for imaging the scrotal pathologies in day-to-day practice, followed by MR, and then if required the radionuclide studies. So as I endorse very strongly that I remember my residency days where linear probe was kept packed in a glass cabin and it was allowed to be used only by my lecturer and associate professor. But you guys are very lucky that this linear transducer lies on your machine now. So technology, time has changed in such a big way. I remember doing scrotal ultrasound on a convex transducer. If you're your lecturer's favorite, then only you get to use the linear transducer. But I think you guys are very lucky. Technology has evolved so much that high frequency linear transducers has completely revolutionized the way we can look at any small part imaging in the human body. Right from up you go thyroid, the breast, the scrotum, and you can do beautiful analysis of clinical pathologies in day-to-day practice. As I endorse that I am a clinician first and then a radiologist, whenever a patient walks into my clinic, I always talk to the patient, take a brief history, what is he suffering from, when the pain had started of his scrotal pain, and then evaluate the case. This is a very important take home I want to give all of you all at the outset of this lecture, that spend only a minute that whenever you start evaluating scrotum, again don't jump on the scrotum. Go back, immediately take your convex transducer, sweep the abdomen of the patient, look at the kidneys, look at the bladder, prostate, in short, look at inguinal canals, and then you can do focus examination of the scrotum. Because the testes in the fetal life were lying near the kidneys. So there is so many concurrent pathologies related to the genitourinary system might be lying along with the cause related to it. So always in habit, screen the kidneys, look at the bladder, prostate, and then jump and see the scrotal pathologies. So I have followed this dictum for last 20 years, and trust me, again, as I was telling you yesterday, Zinner's syndrome, which has ipsilateral renal agenesis, might be there, and you are doing a scrotal ultrasound for infertility, and you might tell the clinician so much useful information which he may not know, because if you don't screen this abdomen pelvis, you would miss that in your day-to-day practice. So always make it an habit, before doing scrotum, look at the kidneys, bladder, prostate, inguinal canals, and then you jump and do the scrotal ultrasound. So if you see, scrotal pain is a very funny thing. Sometimes a patient having ureteric colic typically complains of pain in the scrotum. So in fact, many cases of scrotal pains are actually the terminal ureteric calculi or the ureteric calculi, and these are the real culprit of the pain in the testes, and therefore you should always screen the kidneys, bladder, and that's why in fact many times the clinicians send me for scrotal pain and we'll end up picking up the UV junction calculi, and your clinicians get shocked that it was referred for scrotal ultrasound and you have picked up a ureteric calculi, and you're doing so much good for the patient because you have actually identified the pathology which he is suffering from, and most of the time the scrotal ultrasounds are completely normal. So see this case where there was ureteric calculi and we picked it up, and this was a patient referred for scrotal ultrasound. Second algorithm, very, very important. There is in all these organs which we are imaging, these are all mirror organs in the body. Thyroid, breast. So there is going to be a symptomatic side and an asymptomatic side. Always have habit of first seeing the asymptomatic side, because that becomes your standard of imaging against which the pathological side can always be compared. So keep that in mind. Always see the contralateral normal side first and then go to the symptomatic side. Second, as I said, always go from outside to inside. So look at the scrotum right from going from outside in terms of wall, then you go and evaluate the testes, then the epididymis, then the cord structures, and then the something which is covering the testicular area is the tunica vaginalis. These are the only 5 things if you memorize in your scrotal ultrasound, and the pathologies will be related to that. If you look this as a compartment, you will not miss any single pathology. So in day-to-day practice, this is the scrotal skin, this is the testes. Now, anatomy-wise, I don't want you to tell, because any organ we image in transverse and longitudinal manner. But another important take-home here is that over a period of time, especially, you must be doing a lot of infertility-related ultrasounds related to varicoceles, but start taking testicular volumes. Now, it has been proved that patients having volumes less than 7 cc's are the ones which are hypovolemic and one of the rendering cause of pretesticular cause of male infertility. So in practice, again, develop a habit of taking volumes of testes, but yes, only when the scans are referred for male infertility related protocols, not in any kind of acute settings. So then these are the way the testes and ovoid homogeneous organ, once you have imaged that in the transverse and the longitudinal plane, you will go ahead and start looking at the superior part, which first comes as the head of the epididymis. So this is the head of the epididymis. There, if you rotate your probe 90 degree, you will get to image the entire epididymis. So always look at the head, body and tail. The juniors always have tendency to look only at the head. Do not do so. Look at the body and tail. Some pathologies are mischievously lying at the tail of the epididymis. Once you have seen that, this is the tunica vaginalis, where the hydroceles are very common, so that you can image beautifully. Once you have finished that, majority work is done, and then you go and evaluate the cord, which has the vessels lying within it, and some pathologies are related to only cord structures. So if you have done this compartmental segregation, you have done wonderfully well in scrotal ultrasound. Then in day-to-day practice, you do B mode. Yesterday also I was stressing upon you all that just don't limit your examinations to just B mode sonographies. The clinician wants a complete information. always switch on to color and always do color Doppler evaluation of the lesion. You want to set your machine to look at scrotal flow. So now you always all know that the testes has low flow settings. So there might be a button in your machine. Just click on that, say low flow settings, and that machine gets accustomed. Again, set the machine on the normal side because that becomes your benchmark, and put the same settings on your contralateral symptomatic side, and then you have screen division, and you know that this is looking normal and here there is increased vascularity, and then you know you're dealing something with orchitis. I have seen now majority reports of scrotal ultrasound. We are all very lazy about taking spectrum in the testes. So this is another important take home, that whenever you are evaluating acute scrotum, develop habit of taking one spectral tracing in the intratesticular portions. I'll show you the cases related to that. Then in any indeterminate case, and especially you are lying in the gray zones of whether this testis is torsed or detorsed or not torsed, and you are not getting flow on your normal color Doppler, always power Doppler is your savior, because it can pick up any minutest low flow, and you switch on your power Doppler and you get this thing. So as I was telling you, that you need to set your machine to those settings where you want to see doing color Doppler of the testes. So your aim behind this whole thing is to pick up those minutest flow within the testes. So what you will do is basically the basic protocol. You minimize your PRF, you maximize your color gain to so much that the whole screen bleeds, and then reduce the color gain. You can minimize the wall filter settings, and that sets your machine for color evaluation of the scrotum. These patterns of flow you should always remember. So you should always remember testes is a very important organ to a male body. So the God has devised it such that there is continuous flow throughout the cardiac cycle. So if you see that, you remember your umbilical artery flow, seesaw patterns. So throughout the diastole we are getting good flow. So typical low resistance pattern, forward flow throughout the diastole. This is the spectral tracing in any kind of scrotum Doppler. As against it, spermatic cord, it has a high resistance because a lot of cord structures are there. There is a resistance to the flow. You will get sharp systolic peaks followed by decreased diastolic flow. So remember this pattern. This is about that power Doppler I was telling you, that in case you get stuck up somewhere, you can switch on to power Doppler mode. Interesting is this blood supply of the scrotum, which you need to memorize in your day-to-day practice, because again God has also devised this, that he has given differential blood flow to different parts of testes, as you can see this slide. Now this slide is very important. Why? Because many a times you get confused and flummoxed between torsions of the testes, whether there or not there, because sometimes you see flow at the periphery, but actually this flow is to the different parts of the testes, and the central flow, the flow within the testes, gets compromised in any kind of torsion conditions. So this is all about anatomy related to scrotum. I'll take you to some cases which I have collected in my last so many years of practice, which will bring you an insight how you approach your scrotum in acute pathologies. These are various conditions for which the clinician can refer you an acute scrotum. And one of the interesting and the paramount importance is the torsion of the testes, which will come to you in your day-to-day clinical practice. So interestingly, on a Sunday morning, one MD physician got her nephew, who was a 1-year-old child, presented with sudden onset scrotal swelling, and she had freaked out because the whole thing which was in her mind was torsion of the testes. See how bizarre the whole picture was, that the entire scrotum was edematous like this. Even the penis was completely edematous. And when we started evaluating us, see what we can see. The testes underneath were completely normal. But what we can see, that the wall of the scrotum is edematous. See this, the classical fountainhead sign described, where there is fluid in the scrotal wall layers. But interestingly, the entire testes was completely normal. And this condition is nothing but idiopathic scrotal wall edema. In fact, she was very shocked because she said, torsion dekho, torsion dekho. I said, ma'am, testes are bang normal. This, if you go back and read your Bailey Love, this condition is beautifully described in Bailey Love still today. And they say that a pediatric eosinophilia leads to this kind of bizarre condition where the entire scrotal wall gets edematous, and this seen typically in a pediatric age group, and this is a scrotal wall edema. As against this, can you see this kind of condition in the adult age group? Yes. Any kind of fluid overloads in body like renal failures, cardiac failures are all going to lead to the fluid getting across to the third compartments, and in many such condition this becomes a secondary scrotal wall edema seen in fluid overload state. Young guy, pain in high grade fever, swelling in the right scrotum. The testes were completely normal, but what we picked up was this hypoechoic area in the scrotal wall. This patient complained of pain typically at this site, and day 3 there was complete necrosis with a hypoechoic collection only confined to the scrotal wall. This was a scrotal wall abscess. This guy was interestingly operated for fistula in ano and came with a severe right scrolling and a discharging sinus at the base of the scrotum. Now see what ultrasound could pick up. So when we started evaluating at the scrotum wall itself, what can you appreciate here? Air. Excellent. So see, moment you see air in the scrotal wall, you know that something severely infective is happening at that, which could be either a necrotizing organisms leading to this. And then in this patient, see this, we saw that there was complete air in the scrotal wall. There was ipsilateral epididymoorchitis, and this was a bad infective etiology affecting the scrotum wall with gas forming organisms. So we gave a possibility of all this, and the patient was then subsequently put on high antibiotics. This was an interesting case of a diabetic at one ultrasound done in Karuna Hospital way back, where acute abdomen with bilateral scrotal swelling the patient had developed. The abdomen was completely normal. But again, interestingly, when we started seeing his scrotum, the testes were being normal, but one thin speck of air which I picked up in the scrotal wall. See this, how beautifully air can be seen on an ultrasound, and see this hyperreflective air echoes with posterior reverberation artifact. We alerted the clinician that there seems to be a bad sepsis setting in this patient, and you need to monitor him and see what happened to his testes. This was Fournier's gangrene with complete air in the scrotal wall. There was shameful exposure on day 5. In fact, this patient succumbed the 6th day because of such severe bad sepsis. Then trauma can present to you in different ways. And this was one guy who had trauma to his left scrotum and came with pain and swelling. Now see what you can see here. The testes is completely displaced to one side. But what we are seeing is a collection with moving echoes, history of trauma, 2 and 2. We gave this as a hematocele. Then this was a very bad case shared by my very close Ravi sir from Dubai, where the patient had a bad vehicular accident. See, completely shattered testes, completely disorganized testicular parenchyma. There is an hematocele there, testes completely shattered, and this, in fact, in one more case, there was these cleavages seen within the testes. Can you all appreciate this? These are classically called as testicular fractures. And when you see something like that in a history of trauma, see how this testes was exposed and patient had undergone complete orchidectomy, and we could not salvage the testes which had completely shattered. This was case given by Mohit. Again, because of trauma, there was so much cord hematoma that the blood supply to the ipsilateral side of the testes had completely compromised. Then sometimes the trauma is such to that level that only the tunica albuginea gets disrupted, and these are called as ruptures of the capsular. Can you appreciate this capsular rents? And then there is associated hematocele. Now this was an interesting case again, where a history of vehicular accident had happened 2 days back, and patient again came with pain. And this was a guy who was very coy in nature. We started screening him, and he said left side mein dukta hai, and he kept on shying away. So the abdomens were completely normal. Then I, interestingly, out of my own interest, I said, let me screen the inguinal canal, because he kept on complaining of pain on one side. But see this, what happens. So moment we, you remember there is a rule in surgery that whenever you examine an acute abdomen, always expose the male patient till down, because scrotal pathologies could be a cause of acute abdomen. See in this case again, the testes on the symptomatic side, hypoechoic, inhomogeneous areas, other testes normal. See the B mode, see the color picture, no flow. What are we dealing with? Very good. So your job doesn't end with just putting color in the testes. Always go back, search to the cord. Beautiful sign, again described by our very own Bhupati sir, called as whirlpool sign. Wherever torsion suspected in human body, search for that side getting twisted, and that twist is seen beautifully in the cord, and this was a whirlpool sign we demonstrated in this child, and we know that we were dealing with torsion of the testes. Another case, young guy, sudden onset pain. Now see what has happened here. Testes is normal, but see the symptomatic side. The first thing which strike me is the axis of the testes. Here see the testes axis, and here. Moment the testes axis starts becoming horizontal, always your red alert should be, are we looking at something like torsion? Hypoechoic, isoechoic, difference in ecotextures. Then look at the epididymis, there was secondary reactive vascularity, no flow. Again, beautifully we could demonstrate the whirlpool. Moment you see a whirlpool, you can clinch the diagnosis of a torsion of the testes. This is just a nice case to show you how our ultrasound pictures and surgery, when the surgeons open, can be so good that what we are seeing on ultrasound, the surgeons see introp. So again, another case of torsion of the testes. But see how beautifully the surgeon ko that twist what is seen here on laparoscopy, we could see it so well on ultrasound. So Bhupati sir gave us a very beautiful learning curve in torsions, where if you see real-time whirlpool sign, you can pick up torsions very confidently. As against one case, we had torsion of the testes, but at the superior pole, at the region of the epididymis, I saw this echogenic cystic structure, inhomogeneous like this. I was wondering, I have picked up torsion, what this could be. And I told the surgeon that area is looking like epididymis. Could this be epididymal torsion? And it indeed turned out to be so, that there was testes and epididymis both which had twisted on its own, and this was the follow-up. This is a pediatric case. Now you should see most of these torsions are seen in this 18 to 20-year-old, the adult ones. But now see this case of a pediatric child presented with excessive crying, where on the right side, asymptomatic, there was an infantile hydrocele. But again, symptomatic side, axis of the testes had completely changed, inhomogeneous, hypoechoic, no flow. But what's interestingly seen is beyond the color flow is that there is complete motility going up till the external inguinal ring. Something like this, memorize patterns. If this is seen in a pediatric age group, you are again dealing with something like torsion of the testes. So this brings us to tell you that torsions can be of two types, and you should remember it's that if it's adult torsion, it's the type which I showed before, and when the entire motility occurs at the external inguinal ring, these are those extravaginal torsions. What is our whole aim in doing ultrasounds and Dopplers in torsions is picking up this condition in the first 5 to 6 hours. If we are unable to do so, then it is of no use, because the testes cannot be salvaged. So your job as a radiologist, as an imaging specialist, is to pick up these torsions before the great damage is done. So pediatric age group, extravaginal torsions. Adult age group, typical that bell clapper deformity which we read in our MBBS days, that leads to the twist and leads to the torsion. So adult age group, always intravaginal torsions. Now, this is a beautiful slide which I prepared, where we realize that what can happen in the first 6 hours and how you can pick up. So the only way to pick up these torsions very early is to search for whirlpool. So if you have seen whirlpool, you can alert the surgeon saying that there seems to be a impending torsion, because many a times I have seen in practice that flow within the testes can still be little seen till the entire degree of twist has taken place. So you can do a wonderful job by alerting the clinician that there is a torsion by picking up whirlpool sign. So can torsions occur in an undescended testes? This case given by Mohit, we can see that this was an cryptorchid testes at the deep inguinal ring, inhomogeneous mass, no vascularity, and this was a torsion indeed. You can tell me when to stop because of the shortage of time. Now, this beautiful part of torsions is related to the degree of twist. So if at all the twist is less than 180 degrees, 90 degrees, then we land up with something called as incomplete torsions. So for complete torsions to occur, it has to be a 360 degree, 520 degree twist for us to pick up these complete torsions and see it on ultrasound as a whirlpool sign. So now very important question to the audience. One is, you're doing an ultrasound, you're seeing a color flow in the testes, patient has pain, can there be still torsion? So always very importantly remember why I was stressing the importance of taking one spectral tracing in both the testes is for that, because in all partial torsions, incomplete torsions of the testes, you will always have flow within the testes, but spectrum within the testes will be the only clinching way to pick up this condition. I'll show you by this case. 17-year-old guy with this kind of patterns. So see this, normal asymptomatic side, forward diastolic flow. Can you appreciate the seesaw, the umbilical one? But see what has happened here. The color is there within the testes, but see the spectrum. What this spectrum reminds you of? When we do critically ischemic limbs in the lower limb, this is that typical dampened monophasic waveform where we realize that the blood flow going to the periphery is getting compromised. There is no end diastolic flow, which should have been there in every testes. But when you see something like that, always remember that this case is of a partial torsion of the testes. So reduce. So the criteria to call anything as incomplete torsions on spectrum, you are getting dampened monophasic waveform or reduction in the flow of the diastolic component during the spectral tracing, all could be a clue that you are dealing with something called as partial torsions. So today with ultrasound and Doppler, no need of any other imaging modality. You can stamp and say whether torsion is there or not there. Few other conditions, I think it's a big lecture, but I'll show you all. You all can stop whenever the time goes off. These are testes was completely normal. But see, at the superior head, near the epididymis, we saw this hypoechoic area, typical fine calcifications within it. Seen something like that with peri-legional flow, always, or something that echogenic mass above near the head of epididymis. These are nothing but torsions of the testicular appendages. So torsions can occur in the epididymal appendages and testicular appendages. Only difference is testicular occurs at the upper pole of the testes as against the torsions at the epididymis occur at the tail end of the epididymis. Then see here, you are seeing a wedge-shaped hypoechoic area within the testes. What is it? Is it a torsion? No, this is not a torsion. Why? I'll tell you, because these are segmental testicular infarcts. So you will see only a wedge-shaped hypoechoic area devoid of flow, but the rest of the testes shows complete flow. And these typically occur because of any kind of vasculitis event setting in. There could be underlying epidermolysis, some surgery done, and the only thing differential you should keep in your mind is that any kind of neoplasm in the testes will also show this kind of appearance, but it will always show some flow to call it a mass as against segmental testicular infarct. This is your day-to-day bread butter of you evaluating a heterogeneous epididymis in day-to-day practice. The normal epididymis seen here, you put color, there is increased vascularity, and you know you're dealing with a condition of acute epididymitis. So in day-to-day practice, this is very easy to diagnose when you see inhomogeneous looking epididymis with increased vascularity, typically young guy. There is a history of either urinary tract infection or a sexually transmitted diseases which lead to this, and you get this kind of appearance. Now, your job again as imaging specialist is, one, you have picked up epididymitis. Also evaluate the testes on the same side. If increased vascularity in the testes, there is epididymo-orchitis, as against if it goes up and involves the cord starts becoming echogenic because it has connective tissue within it, and then the whole spectrum becomes epididymo-orchitis with funiculitis. So this is an example of the same, I think here. So epididymo-orchitis, and there will be always increased flow as compared to the contralateral side. This was my own friend, very interesting case where he had a pain and a vague trauma to his testes and ran and came across to me. Now when I saw his testes, there was one again wedge-shaped hypoechoic area. So immediately I said, oh, this is looking like a segmental testicular infarct. But moment I put color in that hypoechoic area, there was increased flow within that hypoechoic area. Whenever you have something like that, this is nothing but focal orchitis. This guy with submandibular swelling and high-grade pain and fever, the testes showed epididymoarthritis, but out of interest when we saw his parotids were normal, the submandibulars were enlarged, inflamed, and 2 and 2 we gave it as an epididymoarthritis sequelae to mumps. So mumps always can cause epididymoarthritis, and that should be remembered in mind. Today WhatsApp goes on as an opinion for everyone. So Hemal, very close friend of mine, shared this case where he was shocked about what he was seeing. So this was one testes which was completely normal, 78-year-old guy, and seen within completely the other part, there was this collection with fine echoes within it. But Hemal was saying, Rajesh, क्या लग रहा है बता करके. मैंने बोला, one thing I can make out is that there is air in the There, one thing I could point out that there was, there was air in the scrotal wall with the posterior reverberation artifacts. But see how beautifully in the videos, the entire testes has completely replaced with this dirty collection which showed air echoes within it. Now, I said I have never seen something like that, but today Google is there with you, so I ran across red. Then I told Hemal, call the patient next day again. Next day the picture became more bizarre when the entire testes became iso to hypoechoic, complete dirty air shadowing within it. The reference which we got for this case that this is nothing but emphysematous epididymoarthritis. Now, classically seen in diabetes. In fact, this work has been done by our Indian team where severe diabetes leads to epididymoarthritis, and with these gas forming organisms, the entire testes gets replaced with this kind of air echoes. Young guy, pain in left scrotum. Now, this is another very important take home which I wanted to give you all. We did this scan of this guy, and what you are seeing is an inhomogeneous epididymis, okay? And we wrote epididymoarthritis. We gave that report and sent away the patient, okay? So the patient was put on antibiotics, but after 15-20 days when he followed up with the surgeon, he said, Rajesh, what have you missed? I can feel a lump in that particular scrotum. So he sent back to me. See what has happened here. After 4 weeks when we scanned him, entire testes had replaced with a hypoechoic collection with internal echoes like this. So what has happened here? Can anyone? Patient didn't have any fever. Very good. So what happens when there is severe epididymoarthritis? You need to know that there is one condition called as testicular infarction, which can happen because the process of inflammation is so much that it leads to impairment of the venous outflow to the testes, and that testes undergoes complete global infarct. And therefore, as a protocol today, after every epididymoarthritis, we safely write to the surgeon or in our reports that follow up after 4 weeks for assessment, because this patient then landed up with orchidectomy because this testes had completely undergone global infarction because of severe epididymoarthritis. Simple cases, high-grade fever. Here the testes was completely normal. Dirty collection, WBC counts high. You know you are dealing with a pyocele of the scrotum. As against high-grade fever, WBC count high, drug addict, hypoechoic collection. This turned out to be a testicular abscess. So the clinical setting, lab parameters, patient's symptomatology, everywhere you need to put 2 into picture and then make a diagnosis. This is another that I think I'd shared this case of this acute abdomen where he landed up with inguinoscrotal swelling. So we had picked up an omentocele. Even that can present to you as acute inguinoscrotal swelling, and then you need to rule out whether it's a hernia containing bowel or hernia containing omentum. So see how beautifully ultrasound can demonstrate omentum. This acute case again was in Karuna Hospital where patient had an inguinoscrotal swelling. Trapped was this bowel, and within the bowel was not getting reduced and had lost its viability, and patient was immediately apparated because it was a strangulated inguinoscrotal hernias. So have a very open mind approach whether it is an inguinoscrotal swelling, pure scrotal swelling, and so forth and so on. So just to conclude, how you can see if you have a systematic approach, look at the clinical profile, lab investigations, a segmental approach to testes from outside to inside. You can almost, with high frequency transducer, make beautiful diagnosis of day-to-day acute scrotum in clinical practice. Now, this is one part of acute scrotum. Other than that, you might encounter scrotal imaging for male infertility. I gave you a dictum that start taking volumes of the testes, which is a marker of male infertility. Always, I want to give you an important take home that if you're doing a scrotal ultrasound for male infertility, always make it an habit for patient to get their semen analysis report. We always have habit, again, just to look for varicocele. Your approach should not be that way. If you look at the semen analysis report, look at the fructose test. If fructose test is negative, that means there is definitely a post-testicular cause of the infertility. By that I mean that there is an obstructive etiology to this patient not having sperms there. Always in those patients, subject the patients to transrectal ultrasound because that can pick up the cause of main infertility. Pre-testicular, testicular and varicocele, you can do a good evaluation by just looking at the scrotum. So if you see small size testes, hypovolemic testes, testes less than 7 cc's, you start and the testes look normal or atrophic, you know that this is a pre-testicular cause of infertility. Then in testicular cause, if you pick up varicoceles, you have done your job where a diameter of 3 millimeter and more, and reversal of flow seen on Valsalva is one of the criteria to pick up varicocele in day-to-day practice. But the most important take home is if fructose test is absent, you should go and do TRUS to rule out the ejaculated ducts or seminal vesicles, because that are the cryptic sites which are leading to the male infertility. Thank you for your kind attention and thank you for everything.
Thank you, Rajesh sir, for a nice talk.
Thank you, sir.
And it's really good that you have not limited your talks to anatomy and demonstrated beautiful cases. And I hope all who are present here will be very much confident in dealing with the acute scrotum and other pathologies henceforward. Thank you very much. If anybody is having question, they can free to ask.
Rajesh, you have got a wonderful collection of the cases. Yeah, really wonderful.